I would like to thank Dr. Kumar and Dr. Ashay for this opportunity. So I'll be talking about what is new in radiation techniques in early lung treatment. Before that, I'll just define what is stereotactic body radiotherapy. ASTRO, ACR, CARO and AAPM National Radiotherapy Implementation Group, they define SBRT or stereotactic body radiotherapy as a method of external beam radiotherapy which accurately delivers a high dose of radiation in one or few treatment fraction to an extracranial target using tumor site-specific imaging modality. The rationale is mounting clinical evidence, modern technological advancements, and recently improved understanding of radiobiology of SBRT. Of course, that's being used in early stage lung cancer, that is T1 and T2, T1A, T1B, T2A, and T2B. Why SBRT? We all know that not too many patients are detected in early stage, and even among those who are detected, a lot of them have great incidence of medical comorbidities. They are elderly, they are smokers, and surgery is often not feasible. So NCCN, if you see in the guideline, it is a level 1 evidence for medically inoperable early stage lung cancer. Now, when did this SBRT start? Because we are all used to doing conventional radiotherapy for lung cancer, and these are the two trials, that is TROG Chisel, TROG 0902 Chisel and SPACE trial. The TROG 0902 clearly demonstrated a superior local control and a longer overall survival, whereas the SPACE trial demonstrated a better quality of life and less toxicity as compared to conventional way of radiation. Stereotaxy, as you all know, as I have defined before, is a way of delivering very focal radiation in a 3-dimensional space with image guidance and respiratory motion management in one or few fractions. Early evidence of stereotactic radiosurgery. This is one of the first trials in 2003. Timmerman used stereotactic radiosurgery, and he defined that 20 gray in three times delivered, that is 60 gray in 3 fraction, is a safe dose for T1, T2 peripheral lung tumor. However, the same results he did not achieve when he used the same dosages for central and ultracentral locations, and the grade 3 toxicity in this group was to the tune of 46%, and he suggested dose reduction for central and ultracentral tumors. There are various evidence over the last 1.5 decades. This is a systematic review, and we have seen that SBRT, that is results with stereotactic body radiotherapy, they are almost as much as surgery independently in 1 year, 2 year, 3 year, and 4 year local control rates are almost similar. So there were 2 trials, the STARS and the Roselle, one in the Europe, the Netherlands group, and one in the US, and they tried to do randomized control trial between lobectomy and radiotherapy for stage 1 non-small cell lung cancer, but unfortunately they could not accrue too many patients. So the total number of patients, although they screened a lot of patients, finally they could accrue. This is a pooled analysis of both the trials, and finally they could accrue only 21 in the SBRT arm and 27 in the surgery arm. So for 58 patients enrolled, the median follow-up was 40.2 months in the SABR group and 35.4 months in the surgical group. 6 patients in the surgical group died compared to 1 in the SABR group. If you go through the local control, this is the local control. I mean, in certain stages, subgroup, the SABR curve was above the surgical arm. However, this trial was criticized because of small sample size, short follow-up up to only 40 months, heterogeneity between study protocol, and scarcity of contemporary surgical techniques such as VATS. So this could not come in SBRT being equivalent to surgery in operable lung cancer, and so far the NCCN says it is in medically inoperable lung cancers. So to address the issues and shortcomings in STARS, they performed revised STARS, that is, they enrolled an entirely new set of patients with similar primary and secondary objectives, but did not analyze the patients from the original STARS trial, and you can see the outcomes, the overall survival, the progression-free survival, and the cancer-specific survival remain similar in surgical as well as the radiation arm. I'll be talking about a few other trials. Saber Truth was a trial which was started in the UK, but patient had pre-existing treatment preferences, and there were more patients who wanted to enroll for SBRT, so this trial was prematurely closed. Now there are ongoing trials, that is Stablemates trial, that is a trial between sublobar resection and stereotactic body radiotherapy, and we will have the results in another 3 to 4 years. Similarly, Valor is another study which is evaluating surgery versus SABR. That is a trial which is doing well, and they have already enrolled 200 patients so far. Toxicities about stereotactic body radiotherapy based on the location. If it's peripheral, it could be chest wall or rib fracture. If it's central, it could be radiation pneumonitis, esophagitis, hemoptysis, brachial plexopathy, and so on. The process, I think I'll skip these slides because these are too technical, but one thing I must say that you must have a good respiratory motion management system, and you should be binning the scans, that is 10 inspiration, 80 expiration, 20 inspiration, 70 expiration. You should be able to gauge the patient in the phase-specific treatment phase where you want to treat the tumor. Dose fractionation, 54 to 60 gray being the common dose fractionation schedule. This is our study. This was one of the larger data published for, larger for Indian patients. We had published a data of around 30 odd patients, and our 1-year survival rates were to the tune of 87% for early stage lung cancer. Astro has now come up with evidence-based guidelines for SBRT lung, and they have posed 4 key questions, which I think all of us should read, and it's an excellent guideline. Immunotherapy, there is a lot of work going on. Proton beam therapy, there are potential benefits in terms of cardiopulmonary toxicity, but there is no level 1 evidence as yet. And the take-home message of this talk is SBRT is currently the preferred option for medically inoperable early stage lung cancer. There are ongoing trials evaluating its equivalence in medically operable patients. Studies are evaluating the combination of systemic therapy with SBRT, and these are exciting times ahead for SBRT. Thank you.
I believe that with improved surgical techniques, immunotherapy coming in perioperative settings, and newer advances in radiation therapies, lung cancer has better days ahead, and we may see more and more lung cancer patients surviving for a much longer period of time.